on this is just going with the simplest of things, the troubleshooting, the do's and don'ts, and what we can help the nurses with. And the first thing I think we should start with is the power button. It's back here. Some of them have a sleeve to cover them, so you don't inadvertently turn it off. And some of them, the sleeve isn't there. So all you got to do to turn it on or off is press this button. If you can turn that on or off, it's fine. The next thing that we do when we do this is we'll do a checkout for the machine, and it's actually, there'll be a test exhalation port on here, and all we got to do is activate that. We'll start the test, and we have to include the circuit, so we can optimize our flows when we do this. So once we've got that, then we're ready to place it on the patient. We're going to place it on the patient. The key to importance is making sure we have the right mask. I'm not sure we set this up correctly to begin with this patient. Anyway, I just grabbed one mask. We have 3 mask sizes, small, medium, and large. Okay? When we fit the mask, I explained this the other day, I have 4 corners of Velcro here. You don't have to attach all 4 corners. We have a snap button down here. On and off, it's just very simple. So when we fit the mask, what we want to do is we want to take the top part of the mask and fit it and put it on the bridge of the nose. And luckily, the small fits this guy perfectly. So what we're going to do, let me hold it. Yeah, it's a kind of almost, you can do it with one person. It's easier to do it too. So what we want to do is we're going to strap the mask here, and then secure it. Come here, and then what we want to do with the top side is place it evenly and not have a lot of pressure on it, but make sure the patient's comfortable. And then we can come down here, and now we've got a place. He's not going to breathe. How do I check my seal? But so we have a leak test down here that we can tell optimally. What are you looking at? Under 40? So I've heard people talk. He says on our total leak on our mask.
I don't know. I'm not an expert.
We do this 20 to 40. I think if we get under 20 or so, it'll be really too tight, and that's what we're going to start worrying about. Our facial bruising on our bridge of the nose. I've seen it happen here. You know, so there's skin breaks down. So we got to cut down on that. The circuits will come in 2 types. We've got just a regular circuit, and then we've also got a heated humidified circuit. The heater will be down here. Troubleshooting, one of the biggest things I'll see with this is a proximal line, measures our pressure. A lot of times, you walk in the room, Bi-Pap will be alarming, and they'll say, "What's going on? I got to fix it." And you walk in there. And all it is this line, and it might be here, it's connected here, and then it runs to the end of the circuit. And what it does is it'll measure our pressures. And either way, it can get knocked off. Sometimes it's as much as just the patient knocking it off with one of their arms or hands, or maybe a nurse doing it with extra cables and circuits and tubing. The other thing I think, you know, a couple of the things as far as the Bi-Paps goes, we can come over to our parameters, and that'll show us our numbers here for the Bi-Paps. Most of the nurses will do charting for the IPAP, EPAP, and the oxygen content. And the IPAP will be 10 and 5, we're set up here, and this one's on 40%. If we want to change that, we can come over and we can hit the monitoring button and hit our parameters button. Come over here, and there's just hit the button where the content is. And all we really want the nurses to do with the Bi-Pap is to wean the oxygen, turn it up or down. You know, other changes the IPAP, and respiratory rate and time of inspiration, we don't want them to do that. So this will go at 100%, and it will turn clockwise to raise it, and turn counterclockwise. And if you notice, the more oxygen that we're training through the machine, the louder it gets. So that's kind of where we're at. We want the nurses to be able to do wean oxygen. The other thing that I think that would be helpful is we can come over here also to the alarms button, and we can hit our alarms and see that. The two things that, I should say the one thing probably be a concern that the nurses could change on the alarm is the respiratory rate, our high respiratory rates, because sometimes we'll have patients set up at 35 or 40 and we can increase it to 50 or 60, whatever we can do to keep the machine from being alarming. So, as far as taking the mask off, last thing, put the patient in standby mode, take the mask off. We're going to want to it's going to alarm as soon as the circuit comes loose. So we can come over here to monitoring, hit the monitoring button, it's the blue button. We come over to standby, we'll hit the standby button. When it goes to black, machine's in standby mode.
How long does it stay in standby?
It will stay in standby mode unless, some of the older machines were much more sensitive, and you could shake the mask and it would send some type of flow and it would go back in to a ventilation mode. Doesn't happen with the newer machines. With some of the older machines it will, so it should stay in standby mode until there's actually something that...
Is there a timer on it?
No, there isn't. So that's where we're at. I think that's what we wanted to cover as far as the Bi-Pap.
Can I add one couple just quick points
Okay, go
about the
ahead.
mask? Do you mind? Okay.
Yes, go ahead.
So Scott alluded to this. The respiratory therapist will obviously be doing the initial fit and setup with the mask. So nursing's responsibility then, when they remove and refit the mask, for whatever reason, they should never have to adjust the Velcro, okay? So the concept behind refit is that you're using the quick release, as Scott mentioned, okay, to remove it. And then when you put it back on the patient, sorry, put this back here. When you put it back on the patient, you're going to just touch it to the bridge of their nose first, and then put it here. Don't go this way. If you go this way, people over tighten it. Okay, it's designed to be a loose fitting mask. So you touch it to the bridge, put it here, and then you buckle it. And then the last step, let me put it back on this guy. Okay, so go ahead and touch it to the bridge, put it under. The last step is what we call inflating the mask, because this is a seal-through flow. The bladder fills up when we have gas flow. Therefore, we want to inflate it by gently pulling it away and then bringing it back, okay? You're making sure that there's no creases. The other thing is that
I know it went that way. It should be lateral, it should be even. You must have a lot said in it.
I think this thing just got a little bit. But your seal is mainly coming through this Velcro on the bottom. That's what you're going to snug up. This is really up on the head, designed to be. Where did this go? This is designed to be really just loose. Okay. So, in other words, this isn't a forehead cushion up here. On most patients, it's going to be resting off the face, okay?
Yeah, it doesn't need to be tight.
And that's what's also going to minimize the pressure at the bridge. If you over-tighten it, you're going to have the bridge of the nose pushing up against the hard plastic shell.
I think that's a misconception that they all need to be tight.
No,
It's
we
all-
want it loose,
yeah.
actually.
Some of the problems we run into is everybody has facial features are different, and one of the deals, one of the things we run into is oversized masks, undersized masks, and then some people just tend to have some really deep indentations. Don't get seals, real good seals with some type faces. Other deals that we can do to help with our leaks and alleviate those problems are to, NG tubes are a hindrance, but facial hair is huge. And sometimes we run into people that have to shave their beards that may have been on for 25 years. It happens, you know as a nurse that it happens. So facial hair, NG tubes.
Will you address a couple of other things?
Okay.
Talk to us about food. So, how long it needs to have been before you put the mask on when people have eaten? Pills, things like that, because we've had some issues lately with people asking me lots of questions, not sure about eating and pills.
I had that come up the other day, and I think that's kind of an individual basis, and some of that has to do with the patient's history themselves. You know, whether maybe a CVA or an aspiration. I would say those are your higher risk type of patients. So,
Do we have a rule of thumb, though, on how long they should wait after eating to put a Bi-Pap mask on? What would you recommend?
what would I recommend? I would like to see at least a half an hour, just like your thought of swimming. You know, that if we can get by without doing anything.
Okay, so why don't you address, because this is
I-
being
I-
recorded, so they'll see it, address why it's an issue to not have someone eat dinner and then immediately put a Bi-Pap mask on.
Well, the whole idea is just because you've eaten doesn't mean you've swallowed all your food, and sometimes there's pieces of meat that hang or whatever, anything in your jaw, and it's as if you've got a high pressure device here, and the pressures change, and what happens is you could take, after somebody's eaten, if you put that mask back on, you can push the debris, instead of it getting in the stomach, we could push it into the airway, and then we have bigger problems. So we want to be conscious of that, especially, like I said, we've had people that we know that have known histories of aspiration, stroke patients. We may have some other patients that may have some type of upper airway issues, or
Let's talk about oral cares and the importance of that with Bi-Pap.
oral cares. One of the things I'd like to say, I think that's important, is because a lot of this is temporary, these circuits, and we're looking just to a quick fix. We may be using a Bi-Pap for a patient with CHF to help ventilate them and also push the fluid out. Oral cares, because they're dry circuits, we tend to have patients that get very dry airways. So it's important that we provide sponges, ice chips, proper cleansing of the mouth, so you can.
How often would you recommend?
How often? I've seen patients complain, I would think every 2 hours. That would be my recommendation, at least every 2 hours. Because it doesn't take very long to dry out, and the thing is, the hospital has a serious lack of humidity to begin with. So we need to be,
Another question for you, I've actually had people ask me this, why is it a problem to put the mask on and then have the machine going?
why is it a problem?
You
Ideally,
put the mask on and you don't have any oxygen flow yet, so you put the mask on and then you get the machine going.
I'm not
Aren't you
sure.
asphyxiating them?
No, you should be affixing it. There's two ways of looking at it. It's just sometimes the patient, the machine will be in a full flow mood when you put it on. I like to actually put it on a patient. I will activate the machine and put it on the patient so they can get used to the flow. So I won't even fast secure the mask. I'll just say, this is what it's going to feel like. Are you going to be comfortable with that?
Right,
And
that's
then-
the right way to do it, but I actually have had people ask me, they fit the mask, don't have the machine on, then.
Well,
put the
you
machine
don't
on.
want to do that because you may not be providing them with any oxygen, and they may need the oxygen. So, for patients, for our OSA type patients, it's a different story. The patients that have sleep apnea, that may be on a BiPAP, that need the ventilatory support because of obesity or whatever, they like to put the mask on first and then activate the flow. That is their preference. because some of them do
But
not.
do they have it
they
open
don't-
to air?
There's an anti-asphyxiation valve
Oh,
right here.
perfect, okay, good to know.
However, you know, if someone's really air hungry and you don't have a flow moving through, they're probably not gonna fight you. Yeah.
Whereas you have patients that are used to that, and you're using it for basically airway splinting, they're stable. So it has to do a little bit with the patient itself and how stable they are from a respiratory standpoint. OSA patients that are using CPAP, BiPAP, they're stable, not a big deal to put the mask on first and then activate the machine. Patients that are here in respiratory failure, the oxygen and the flow should be running right away. Good question.
So, a little bit of leak is okay. That's what we want with the loose fit. And that's gonna really help with minimize your skin breakdown.
And getting back to, not only, we talked about the masks, we do have the full face mask for patients that tend to get agitated or have some type of claustrophobia. Basically, it's triangle shaped, looks a little bit like the old hockey goalie's mask. It'll work that, and we can also use it with tracheostomy patients and place them on the trach. Definitely recommend that those circuits all be humidified for our tracheostomy patients. Most of those patients will be using those units at home. Any other questions?
What is our current plan if patients come in with their own CPAP machines and they have a history of sleep apnea? Do we regularly call Biomed, and what do we do if they come in after hours when Biomed isn't here?
We can activate the machine and actually okay them. There's supposed to be stickers that we place on them. Basically, when we examine the machines, there's two things we look at: is proper wiring. They do not allow the old 3-prong setups anymore. It has to be a 2-prong. And the other thing is we have to check the filters, make sure they're clean, and that the machines are clean themselves. It usually isn't too much of an issue with most of the machines they bring in, because they're told that when they come in. If you're compliant, the patients are compliant, will take very good care of their machines. The patients that are non-compliant, they'll bring them in. You can tell obviously right away, because the water reservoirs are dirty. They haven't been cleaned. Filters will be dirty, machines are being dirty. And just because a patient hasn't ordered to wear their CPAP and has had a sleep study, and if they're non-compliant, then they don't have to wear their CPAP or BiPAP. They still have those issues, that's still their choice. So I could think of maybe the 10 years I've been here, maybe 3 or 4 times where I've refused to put a patient's CPAP on because it was too dirty to wear. So, and then as far as the BiPAP and the setups, we do have a department protocol that when we place the BiPAP on a patient, and it basically starts at 10/5 and keeping the oxygen saturation levels above 90%. We can adjust the IPAP and the EPAP. We'll try to calculate a predicted tidal volume for the patient and adjust from there. Because the last thing we want to do is underventilate the patient. And if that's an issue, usually within half an hour to 45 minutes, we can tell if this is going to be effective or not with somebody that's in, severe respiratory failure, and we can go ahead and